Hey there, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Woody, and he's going to talk about diagnosis and treatment of men's pelvic health using MDT. Woody is a physical therapist, McKenzie certified, and he also has a background as a medical doctor in orthopedic surgery in China, specializing in spine injuries and trauma. I hope you enjoy the show. Hi Woody, welcome to PT Pro Talk. How are you today?
Hi Mariana, thanks for having me. I'm doing very well. And you?
I'm doing well. We're here recording Saturday morning and I'm ready for this weekend and excited to talk to you. So let's get going. So tell me just a little bit about yourself, your career, and how did you get to where you are right now?
My name is Dee, but most people call me Woody. I came from China about 10 years ago. So right now I'm working in Canada. I own a private clinic, so I am a licensed physiotherapist with a specialty in pelvic health, especially in men's health. I've been working in the field for about 8 years, but in China, I had a background in medicine. I trained as an orthopedic surgeon. I practiced surgery for about 3 years before I leaving China. And when I came here, so my initial plan was continuing, finishing my equivalency. So I did all my credential exams. At the same time, I went to McGill for a master in physiotherapy. So my goal is just, okay, so this is probably something, even in the past, I work with, some physiotherapists per se, but I'm now really understand what really physiotherapy is. So, and training at McGill really gave me the chance to understand physiotherapy better. And I completely, changed my my career. So I decided to stay in physiotherapy. And I do feel there are a big gap between medicine and physiotherapy, and there's a lot of misunderstandings from each other. So that's become like my passion. So, and I just doing more and more work, try to bridge the two parts together. So that's where I am now. So,
well, that's an amazing story. And I'm curious to ask you about like the differences that you see now that you have both formations in your career. So how do you think that as a doctor, you saw physical therapies before? Because you told that you didn't know much about it. And now as a physical therapist, do you see the physical therapy's relation with the orthopedic surgeon or orthopedic doctor per se?
It's definitely, that's a huge, I cannot even explain as like my, my thought on it. So when I was in China, after the surgery, normally we have a protocol to follow. So we have this, we call the physiotherapy, but actually it's similar to, technician level. So they did a college level training, and they have a little bit of medical background, but most of them, they use traditional medicine like acupuncture, electrotherapy and mobilization. What they do, actually, they follow your protocol. And I think that's still quite the case in many of the China at the moment. So I was thinking, hey, just like, I gave them, a protocol they follow, and that's probably all physiotherapy can do. They can manage them, with some pain, help them to get back to their life faster. But when I came to Canada and then start, doing my master in physiotherapy, they say, hey, there are so much things I don't know about that, There are so many things actually we can do probably, and we don't have to get to the surgery part. So that is a big change for me. I think now and more I see like we can do so many things, help the patient get better, eliminate their pain, improve their quality of life without doing surgery. Surgery is quite invasive. It's a big thing for many people. And this is also giving me the chance to reflect on my past practice. Hey, is it like something I do too quickly? Did I go to the surgery, maybe didn't even give the patient chance to recover. So, and before I only think about rehabilitation is only do after the surgery. So, but right now there are so much things we can do even before the surgery. And just physiotherapy, like if the field is still expanding, you can see people doing not only musculoskeletal conditions, they treat, more complex issues in terms of, more complex cervical problems like post-concussion syndrome, cervical valgopathies. And, in my clinic, we start to develop specialties in treating gastroenteric pains, reflux disease, IBS, many constipations. So there's so much things we can do. And it's just amazing,
I just think it's so interesting that you pick like these two different professions, because it's almost like if you are a good PT, you're going to do your best to don't let the patient to go to have surgery, and you as a doctor, you probably wanted to operate. So I think it's just interesting, the conflict between the two careers. I think that's it's funny how life ends up doing things with us, like it takes us in different ways and different paths. And I just think it's funny.
Yeah, frequently we think there's a conflict, but I think from my point, I think I'm advocate for both actually. There is a place for both sides. It doesn't mean everything we have to manage conservatively. It doesn't mean, surgery, there's no place. For certain conditions like cancer, trauma, fractures, all these deformities, like this is surgical field, but there's definitely a lot of conditions, physiotherapy can play an important role at. So definitely, I just feel like there should be a war between, them. We should collaborate, and all we care is just make patients get better. That's our goal. Yeah.
Yeah, absolutely. I think it's so important that you as a doctor know how much our patient can actually improve having physical therapy, and being aware of that in the role of PT, and also us as PTs knowing that we can go until certain point, and some people, they really do need surgery, and then you just refer them to the doctor when it's time. So just knowing this perfect timing, I think it's very important. Okay, so now let's start talking about pelvic health. So I watched your previous webinar at the McKenzie Institute about pelvic pain, and I know that you use the MGT classification and apply it to pelvic floor patients. So just could you tell us a little bit more about that? I know you've been innovating in this area, so just tell us how all of that started and what have you been doing?
I started practicing in pelvic health about, let's say, about 8 years ago when I graduated. So at the moment, I start treating only female urinary incontinence. So that's how I start, And probably that's most people, they start, they start from treating incontinence, and then with experience, they start to treating pain. So, but there are not a lot of male physiotherapists actually practicing in the field. So it's quite a challenging field. You talk about a lot of, sensitive topics, you share about, intimacy with your patient. And many people, they don't feel really comfortable to share these stories to a male therapist. So at the same time, I fall in love with, McKenzie method at the moment. I think we call that, and it's MDT approach now. So I just feel this is an amazing tool, to use in my musculoskeletal conditions. For example, a lot of, extremity pain is quickly resolved by repetitive spinal movement. So this is quite amazing. And in the literature, you can see people aware about the spinal influences in the pelvis. There's many researchers done already. They talk about intra-abdominal pressure, back pain linked to pelvic floor dysfunctions. But in the practice, we don't really look deeply. Basically, we do a range of motion testing for the back and try to say, hey, there is nothing wrong with the back. Or either we feel something wrong with the back, and we don't know, whether this is related to the pelvic symptoms or not. So then that I start to incorporate MDT in the pelvic practice, and just so amazing, you see more and more changes, basically with spinal repeated movement. And most of the patients, actually, that's what is my practice states now. Like most of my patients actually don't have to do an internal pelvic floor examination and do pelvic floor treatment. So they were quickly resolved by treating the spine. And we are currently conducting a reliability study, and we are is finished the data collection. We are on the way to do the data analysis, and I think it's a quite exciting result. And we can see through the 3 physiotherapists, we all use MDT approach in the pelvic practice. We quite reach a good agreement on the classification, and also about 50% of the pelvic case mixed both men and women actually are a spinal derangement.
That's crazy. That's so interesting too. I think it's an eye-opening experience that you're telling us, and I'm very curious to see this study, because that's something that maybe we talked before. We know there is some relation, but we never actually do something in our practice or see anyone doing it. So I think that's amazing. And what type of clients do you see? It's more women, men, and what is the most common type of issues, either for men and women?
I treat mostly men, but I occasionally treat women, but that's really not my common cases. So for men, I treat mostly almost 90% of pain, and sometimes I treat about 10% like a pure sexual dysfunction, like patient have no pain, just come for erectile dysfunction, ejaculation disorders. I don't treat a lot of incontinence at the moment. It's just like because people refer me patients mostly because they know that I treat a lot of pelvic pain for men. So, but before, when I started, I would treat the opposite. I would start about 70% of incontinence and about 30% pain. But right now, 90% of my cases are pelvic pain case, and the majority, 90% of them are more than that, are men with pelvic pain.
Okay, and so on average, what is the incidence rate of patients who have erectile dysfunction or pelvic pain that is related to back problems?
Oh, that's a lot. The more we explore, the more we feel there's definitely at least half, from my experience, at least 40 to 50% of patients have pelvic pain, and the pain will resolve quickly by treating the back. So that's identified as a spinal source. So it's definitely a lot, not only just the pain, urinary dysfunctions, urgency frequencies, constipation, sexual dysfunction. Many can resolve quickly with their with repeated spinal exercises.
That's very interesting. So could you just quickly walk us through your process of assessment, and then how? So what you always test the spine first? Do you follow the same rationale? So first you exclude the spine, and then you go to the other route. So how does that work in your practice?
Yeah, I think the same process as treating an extremity per se using MDT principle. The key point you always have to establish a good baseline. This baseline can be pain and many pelvic symptoms can be established as a baseline, and you always go through rule out the spine first, and then you move down. You can do abdominal pelvic testing and try to rule out whether there is dysfunction. Dysfunction such as contractile dysfunction, and there's percentage of articular dysfunction happening in the coccygeal joint. And then if it's not falling to the two category, you can further, classify it as other subgroups. So we do see similar presentations as peripheral nerve entrapment, such as pudendal nerve. We definitely see chronic pain syndrome because there's many psychosocial influences. MURs, it's like there are some patients have this sacral neuropathy and have all these neural symptoms, change of sensation, change of muscle contraction. We definitely also have mechanical inconclusive. Many things we see in the extremity exactly we can see from the pelvic population.
And I'm curious to know, how do you manage dysfunction? Either like contractual and like, do you have articular too? So, and how are your pelvic floor tests and procedures? Because I remember about your webinar that you put it there like loaded and loaded and then active and passive and resistant. So how does this test works, and how about the dysfunction?
Okay, so for dysfunction is similar to like we treat a contractile dysfunction for the extremity. So basically you have to identify what kind of a loading can produce their symptom and follow the same pattern as produce no worse. So that's why, sometimes the pelvic pain, they may not be produced while in lying. So if that's the case, you do give someone exercise just lying down there and contract, relax, you may not have the effect you want. So patient may have more loading in terms of sitting or standing, or either with some other activities. But your goal is always try to produce the pain but no worse, and follow the loading strategy to the pelvic, the tissue. And some may change quite quickly if that's the contractile dysfunction coming from the muscular fibers. They may adapt quickly. And if from tendon junction, they may have to load it a bit longer. So, but the same principle, you explain to the patient, you see that when you do it, this is produce your pain and produce, just follow the treatment, produce no worse. And they understand that. And normally after a certain amount of loading times, and the symptom will start to change and tissue will start to adapt. So yeah, that's sometimes we also use some definitely passive treatment sometimes. I mean, passive treatment in terms of passive load, sometimes patients have to practice using insert something. For example, let's say I have a patient, he practice anal penetrative sex, receptive sex, and he has this pain actually due to scar tissues around the pelvic floor, which has happened in the past after, unpleasant sexual intercourse. And for that, you really have to help him, use, we use different insertion equipment and desensitize tissue and load the tissue and gradually the tissue, adapt. So yeah, so similar to the extremity, it just you have to be targeting the tissue you want to load for dysfunction.
And is that like easy to do on patients? Are they open to try these things? Is it like hard for them to be aware of like how to contract or how to do things? Like, do they have any problem with like doing it and let you help? So how does it work?
I think that most people, they don't have the problem to do it because when we, after classification, we explain to them, and most patients, they understand perfectly what we are doing and what you are looking for. And especially when you do exercise actually is meaningful for their, for what they are looking for. For example, if people have people coming to the clinic for a painful defecation, but mostly related to a past surgery of, several anal fissures and also the hemorrhoid repair. Definitely, you give the exercise, patients understand clearly you are trying to, desensitize the tissue. And what we do many times, we insert in a small balloon, called balloon technique. You mimic the stool, and while we load the tissue, the pelvic floor, and try to, practice defecation techniques. So patients, they like this exercise because they gain confidence. They don't, they can do it at home. They don't feel that it's complicated. Many people, they like that. I have a lot of people, they have this defecation pain if it's contractile dysfunction, and we do this technique at home. Patients love it. And for certain patients, let's say I just mentioned, for people who has anal pain due to receptive anal sexual intercourse, and that's what their goal. They have a pain, they cannot, having sex anymore, but you tell them this is how you get there, and by gradually load the tissue. So people, they accept that and they don't feel bad about it.
And I imagine many of these cases, you don't have the answer right there, because sometimes like they don't have the problem right there. So then you apply the treatment and they go home and then they come back and let you know if had any change, and you go from there.
Yeah. So basically you have to find a baseline, what you can track at home, what you can try in the clinic. So for example, something they can change quickly if, let's say, pain, they may change. For dysfunction, it may not change quickly, but in the clinic, you try to practice with them, tell them, this is what you want to get the sensation, like the pain, like just around 4, 5, no more than that. And you really have to load in with the symptom, like always produce no worse. And you tell them the pain should, settle down within 10 minutes after exercise. You educate them, you practice with them in the clinic for a few sessions, and then they can easily do it at home.
Awesome. And do you see articular dysfunction too?
Yeah, we definitely see articular dysfunction mostly from coccygeal joint. So especially after a fall, people have a sports injury, they have a fall on their buttock, and after a few, probably at the beginning is like a manifest as a trauma. There's a swelling, there's a wide pain, but then after a few weeks or few months, the pain becomes intermittent, very localized, related to sitting, or may related to sexual intercourse or defecation. And pain is very localized, and it will be only produced by, at the range of either flexion or extension, mostly towards to extension. That's from our experience. It's not very often. I would say if we have 100% people coming, man has pelvic pain. If we have 50% at derangement, let's say about 20% are dysfunction. And out of the 20% dysfunction, I would say less than 1% are articular dysfunction. And that's exactly the typical symptoms of only localized coccyx pain, coccydynia.
And how do you take them to end range? Is like doing extension, like spine extension and like spine flexion? Or is there any other different way?
If it's like a restricted to extension, it's quite hard to patient treat by themselves. I do have some trouble sometimes get them to do, because it's not something, the coccyx anatomy, you have to, normally we put one fingers inside, and actually that we can push the coccyx to low to the extension. Definitely it's still challenge. So that kind of case, most of the people, they come here and we try to, how to say, in the clinic, we quite do a few treatment in the clinic. But let's say patient, they are actual flexion, they don't have a lot of pain when we push to the extension, but we load, as soon as we sit down the coccyx and they produce this pain, no worse. So for that kind of case, what we do, we definitely, we do some, ask a patient, they put something, a towel in the perineal region, and they can hold their hand. Actually, while they sit down, they go to flexion, they use the towel, apply over pressure, to produce that pain, but the same principle, produce no worse. And that we can see definitely some successful result. But it's really depending, it's not very clear many times because coccyx is very small joint, and there's still not a good, many people that are different. We're still not sure, whether we see that, the restriction at the end, is it really, reliable by physical testing? But you have to go with the pain, right? So if you, oh, that's my pain, when I do pushing to the extension, at the end, that's my pain. And you follow the produce no worse, that's what we do from internally. But from externally, we can actually we can do to flexion. And if the patient has a lot of pain with the flexion, that's what we load. We load to flexion. So this is not that clear, but we do see a pattern of dysfunction, articular dysfunction in the pelvic, but definitely it's not as clear, when you treat elbow compared to left and right.
Yeah, that's very interesting, very interesting. And then it's not, let's say that you excluded the arrangement, is not dysfunction, and then you go to others. So how do you manage this others classification?
It's depending on the subgroups of the other category. So if it's chronic pain, we definitely do a lot of education, patient education, pain education. If you see a chronic pain picture, widespreading pain, and linked to a lot of kinesiophobia, yellow flags, definitely you have to address a lot of the pain drivers. We do have sometimes MRIs. You may sometimes have to collaborate with doctor, schedule maybe injection if the pain really doesn't change. And the doctor I work with, they do a lot of pudendal nerve injection, or they block the sacral plexus. And with others, you just follow what already, you use your McKenzie training and you apply to your pelvic population. And sometimes you have to tell them, if this pain really is not worse, you have to start gradually to get back to your sexual function, sports activities. You really get back to their function quickly. You treat their pain and function at the same time. So they're, I think, similar to extremity, other subgroups. We don't right now have a consensus on how to treat these groups. Even for the classification, I think we still have a little bit discussion. But I think with time, the more we see, because I think that still we don't understand these groups too very well, especially some of the mechanical inconclusive issues. We're not really clear about that. So I think that's with time, the more patient we see, probably the treatment will be, better. The result will be better, yes.
Yeah, for sure. And do you see a lot of psychosocial too?
Definitely, that's really a lot of things.
I imagine.
Yeah. We do I think anxiety, depression is very common. We just did our study. I think we have certain amount of people that have anxiety, depression as a comorbidities. But not necessarily I have this before, is when they have pain and they develop anxiety and depression as a secondary problem. And then we do see a certain amount of people have sexual abuse history, a lot of relationship issues, sexuality issues, body images. It's more complicated than a regular elbow pain or shoulder pain. Definitely, there's more things to consider. Yeah.
Oh yeah, for sure. And then sometimes do you have to refer them to like another healthcare professional, or like are you able to help them there?
It's really, I think we have the powerful tool is really to find whether this yellow flag is secondary to the case, the pain, or is the primary drivers. So let's say if, patient, pretty well before the pain, and then it's clearly, he said everything's happened after the pain. And so if you can successfully manage the pain, many of these yellow flag psychosocial issues will likely to get better on its own, and I think as a physiotherapist, we spend time with patients. We already have our tools to help them to manage certain degree of psychosocial factors. But let's say if the patient coming in, I definitely see I cannot even do a proper examination. There's a patient say coming in, I don't want to be looked, I don't want to be touched, and not because of you, because this is just my culture, my belief. And that patient tells you directly, think about this may link to some, sexual issues, sexual behaviors. So we know this kind of cases, would be better to collaborate with other health professionals like psychologists or sex therapists, and to manage these issues before we manage the pain. So you need a collaboration. But I think we, as MDT clinicians, I think we should have the capacity, and the knowledge differentiate whether the psychosocial factor you should address immediately, or you can wait until the pain settles down.
Yes, makes sense. And on the mechanical inconclusive, so do you see them like long term, if they move and they are just being active, do they get better, or like how that goes in like long term? How is your experience with that?
I have a case, this young guy, he had this like pinching, burning, a pinching sensation in the tip of the penis. It's really, he always just described it as a pinch, someone squeeze it, that's it, And we do, and that's the thing, and I pretty much explored everything, all the movement in the clinic. So I give tracking exercise at home, and just like when he bring back, you just see there's no pattern. Sometimes it happen in flexion posture, sometimes happen in extension, sometimes happen in the static, some loading, sometimes happen during the section intercourse. It's just like so unclear. Sometimes after masturbation, sometimes in sitting. It's just like, it seems to me, it's changing with mechanics, like with different positions, but it's really hard to track a pattern. So for this kind of cases, basically encourage them to do everything that they want, and mention that sometime, we feel some sore or sometime part of body discomfort. It's like it's normal, but the thing is, like, the more you put attention on it, so maybe that's, you more notice that, and you try to encourage them. This guy, he tried to stop, seeing his girlfriend and whatever. But what I did, nothing wrong with you. All the tests are normal, and you have pretty much good physical active function. Your range of motion is perfect. Your pelvic floor seems contracting perfectly. You explain to them, you educate them. There's nothing wrong physically, and get them to their function back. So that's the treatment, And I think this case, I didn't have a very long follow-up, but I think he, after, before we discharge, and he said, one thing I can make sure that is I gain more, confidence. I'm not scared, and that's something I think we can empower the patient.
Yes, and probably helps a lot just by them knowing that they don't have anything physically wrong with them. So
yeah.
And how do you see this moving forward, like this McKenzie approach on the pelvic health? I have many colleagues. I'm from Brazil, and like we have a big group there. and we have many people interested in this area. And I heard you discussing about the forms. I know that you use some forms, but they are not available because you've been developing them. So how do you see this moving forward in the future?
I think we are moving forward quite quickly. So we are pretty much, I think we're going to finish the reliability study by the end of this summer. And then we have a coming study for GPAL study, which is genital urinary pain syndrome of a spinal source, similar to the XPAL study Richard did. And we collaborated with Richard and three other state clinicians. And so we are working on the research and try to, improve the classification, because during the reliability study, we realized that people sometimes would do mess up with the dysfunction and one of the issues, like we need to define what the pain location actually can be produced by pelvic floors tissues. And this is something we definitely need to work on. Regarding the forms, I think after reliability study, we can pretty much identify what the part we need to improve from the form. And I think we can work on the second version. And then when the study shows we have good reliability, I think pretty much the forms will be available to be used. And I'm on the way to discuss with the McKenzie International. And hopefully in the near future, like within a year, we should have this master class of pelvic, MDT pelvic master class. I think that can be something, if in the Brazil people are interested, definitely, I can go down there, and it's like additional training to what they have. So I think can be quite interesting. I definitely see this is a field expanding and in a very positive way and have more and more influences.
That's very exciting. So we are not too far. That's
definitely.
Great news.
Hopefully, the discussion, with the McKenzie International. So we should, have just reach some agreement in terms of how this course will be given, what kind of materials. But the outlines there, we already work on the outlines. It's going to be a 2-day course, and just hopefully everything going to move very well. So it should be a great, learning experience for many of the folks.
That's nice. Awesome. I'm excited. So let's transition to our final questions. So what is your favorite resource of information? Do you have any specific paper, like something that you would like to share with us?
I think the case study I published in 2017, and Christine also published a case series in 2019. I think this is the 2 papers definitely is the best material so far to give you a sense how you will apply MDT in the pelvic population, and what are the research, there's supporting evidence on this using this. You can see definitely there's a lot of research supporting using MDT, because like I mentioned, even people they are aware the spinal issues can refer the pain to the pelvic, but just there is no such a good way right now so far to rule out the spine efficiently. So I think MDT is definitely a great tool. From all my trainings, is you can pretty much, if you have a certain amount of training, you can pretty much rule out the spine efficiently. Yeah, so that's what I see. Yes. If you want, I can send you the 2 articles at the end, and you can share with your colleagues. So I think that's probably the best. Yeah, to start. Yeah.
That would be good. And then I can put also, I can send you my email list, my subscribers, and then also maybe put on the show notes so we can do that. And what would be the best advice that you can give to the clinicians that are starting their careers?
I think that's just be, brave, be courageous, and, open your mind, be open-minded. There's many things we can do. I'm not talking about we're going to save the world or whatever we're going to. It's just like there are so many things we didn't explore in the past, So don't, as long as you have your good knowledge or your rationale to apply the techniques, and don't afraid to explore. And that's what I did with my patient with pelvic pain. And also we explored the pain with abdominal pain. We explored the issues with tinnitus, dizziness, swallowing issues. I have a patient just coming in with swallowing issues, resolved perfectly with cervical retraction. I mean, you need to be rational, and you need to say, okay, I'm gonna treat everyone with that. No, right? You know what you are looking for. You have good baselines, and you monitor your baselines with proper loading strategies. If it really get changed positively, that's amazing, But if it's not, that probably tells you may stop and refer to someone. So that's my advice for the young MDT clinicians. Keep your mind open, and there's a lot of things interesting waiting for you to explore.
Think outside of the box, because you've been seeing many different things and applying to many different situations and having good results. So it's just, we never know if you don't try. And
yeah, that's my experience, because I think I'm lucky enough to see both sides of the medical field, conservative, invasive, and with medication. So I think there's a miscommunication between the professionals, and there's nothing wrong, to try new things. And that's how we develop things, all the medications we developed in the past, they are developed by accident. Viagra, I told my patient, how Viagra developed, that's by accident, many things like that, but we need to have a good knowledge base and, rationale, that's the key factors.
We have topics here for many, many podcasts. Oh, yeah. That's so interesting. Let's go to our final question. So what personal qualities or abilities that you think are important to become a successful physical therapist?
I think the physiotherapists, we are amazing professionals, I think, and one of our advantages, actually, we have the time really to spend with patients, okay? So if you want to become a good physiotherapist, I think one of the things you need to take advantage is the time you spend with patients. Be a good listener, be a good communicator, show your compassion, show your passion, and that can be really helpful for your patient. So many times I just spend 1 hour talking with my patient, and they just feel so empowered, that's what I think, take your time, never, we see the problem, many problems in medical field is actually doctor has no time to speak or listen or communicate with their patient. And this, I think, is a big failure of probably whole medical system in the planet. But physiotherapists, we are there to listen to our patients. We are there to empower our patients. We are there to help the patient to understand their condition better. So, take your time, show your compassion, show your passion. That's I think the quality a good physiotherapist should have.
Awesome. Woody, thank you so much for taking the time to talk with us and share this great news and all this amazing innovation that you've been doing with MDT and pelvic health. That's very exciting. Thank you for all of your contribution. And for the ones that want to know more about you or maybe ask you questions or something, because that's a super new topic, how they can contact you?
I have my email address. I probably gonna give it to you, and I think an email probably is the best way to connect with me. Let me just I have an email for MTT folks to ask me questions. And it actually, since the 2 webinars I gave last year, I received just 60 emails within, I think, 3 weeks or something like that, which is quite encouraging for me. People, they say good words, people ask me questions, and people from all over the world, from France, from Denmark. Just exciting, So my email address is Woody, so it's WOODYMDT@gmail.com. So, you can share this with, the clinicians in Brazil, and anyone who has questions, just feel free to email me, and I will try my best to answer in a timely basis.
Awesome. Thank you so much, Woody, and I really appreciate you taking the time.
Okay, thank you for having me here, and good luck.